Welcome, everyone, to the second keynote of the second day. Today, I am here with David Contorno, who is the founder of ePowered Benefits. He's also received a whole list of accolades, including Forbes, as one example, deemed him one of America's most innovative benefit leaders. So you can read all about that on his bio on the website. So, welcome to um, the Aspiration Healthcare Conference, David.
Thank you.
If anybody has any, I'm going to ask David a bunch of questions here, which are burning. But if anyone else has anything that you think would be important to ask David, just put it in the chat, and I will definitely make sure that we get to them, or David will answer them directly. Um, so let's start here. Let's start at the very beginning, David. When you meet with an employer customer for the first time, what do you talk about with them?
Well, for anyone that has heard me speak before, they know that I definitely take a challenger sale approach or making people uncomfortable. And so I often start off with saying, especially if it's the owner or the CFO, that I owe them an apology on behalf of my entire industry for how we've been handling their health insurance renewals for the last 20 or 30 years. And of course, this raises an eyebrow. They're like, well, what do you mean? And I said, well, the analogy I use is imagine any one of you went to buy a car and your car payment, your budget was $300 a month. But the car salesman was so good that you wind up with $1,000 a month car payment. And a few months later, that car payment is just choking your family finances. So you and your significant other sit down at the coffee table one evening and you say, we have to lower this car payment. Is an effective strategy to call up Geico, even if you save 15% on your car insurance and switch your car insurance from Allstate to Geico, is that going to lower your $1,000 a month car payment? Of course not. Or what if you raised your deductible on your car insurance from $500 to $1,000? Is that going to lower your monthly car payment? And the last thing is, what if you were to self-insure your car insurance? What if you were to put money in the bank, say, forget this insurance, I'll just pay. I know you can't. There's regulations. But if you could, is that going to lower your car insurance, or your car payment, I mean? And the answer, of course, is no. And similarly, switching from United to Blue Cross, raising your deductible, putting in a high deductible health plan, going self-funded, none of those things are going to lower your healthcare costs either. We've been trying to fix health care through health insurance. It doesn't work that way. But if we fix how we pay for health care, then the health insurance gets better. And so that is my initial apology to that employer.
All right. Well, that begs the question. Are you saying, David, that health care is not the same thing as health insurance?
For some reason, we intermingle those words in the American vernacular. We don't intermingle life and life insurance. We know those are two very different things. Or homes and homeowners insurance. Like, those are very separate things in our brain. But I remember seeing an article on the front page of the Wall Street Journal that said healthcare costs skyrockets, and all it talks about is the premiums that Blue Cross and Blue Shield and the individual exchange were doing that year. That's not the same thing. There's of course a relation between the two, but it's the opposite of the relation from what most people approach the system.
Interesting. So I just want to go back to the first thing that you were talking about when you were saying that, about approaching insurance renewals. So most of the time, the way that looks, cue scene, broker walks into employer and talks about, how much the premium's going to go up this year. If I'm an employer, I'm obviously counting on my broker to be working in my best interest there and to keep that premium increase as low as possible. Is that a good assumption?
Well, there's two false assumptions in there. Number one, that any increase is as good as possible. Okay. Our plans see major decreases, for example. So the fact that the increase with one broker was 8%, another one was 11, I don't know how much value that really brings. But the other notion is the broker really working on your behalf? And I know there's some strong relationships out there with brokers and employers, but at the end of the day, most brokers are paid in a way that's contrary to the interests of the employer. Most brokers are paid a combination of commission plus bonuses and incentives. Those are paid by the insurance carriers. And I assure you, the insurance carriers structure those in a way to most benefit the insurance carrier, not the employer. And a couple of examples, I would get around this time every year, because in our cycle, we're starting to think to the 1/1 renewals, which is the busiest month for renewals in the country. But I would start to get calls when I was dealing with the traditional carriers saying, you know, David, if you write just one more group, your bonus is going to be 250,000 instead of 100,000. Or David, if you lose one more group and move it to another carrier, you're going to lose your bonus completely. I would get those calls. I'd have executives come in and meet in my office and basically threaten the bonuses, or sometimes to even cut my contract if I didn't do what was in their interest. And I remember showing them, like, how do you expect me to sell this? Look at this compared to this. How do you expect me to sell that to a client? But at the end of the day, another thing that I say that sometimes makes people uncomfortable is our healthcare system, despite what a lot of people think, is actually not broken. It's working exactly as it was designed to work. It just wasn't designed by employers, doctors, or patients. So it's not working well for those three entities. But again, the broker is paid commission. So as your rates go up, if you're an employer, how much money the broker makes goes up. After that, the insurance companies are held to medical loss ratio provision of the Affordable Care Act. And that means for every dollar they collect, they have to spend 80 or 85 cents of that on healthcare costs. So they get to keep either 15 or 20%, but 15 or 20% of a bigger number is a bigger number. And the only way for that top number to get bigger is for claims to go up. So contrary to what a lot of people believe in the country, insurance companies don't maximize profit by denying claims. They maximize profit by ensuring the largest, most expensive claims occur. So now you have an insurance company that makes more money as costs go up. Within every plan is a pharmacy benefit manager. And if you're self-funded, you have a little more exposure to that, but you have it in your fully insured plan too. You just don't have a choice. The more drugs they fill, the more money they make. The local health systems, they're the ones benefiting from these large claims. So the more that the reimbursements go up, the more money they make. And so everyone that we trust, in at least for half of America, because half of America gets their health care or health insurance through their job, they benefit as costs go up, as severity of claims go up, as frequency of claims go up, and as quality of care goes down. That's what maximizes the profit in all those entities. And yet we keep wondering, why do costs keep going up and quality keeps going down? That's your answer right there.
Yeah, it's interesting. And, you know, I think one of the things that carriers really don't like is unexpected costs.
Right.
They love expected costs because then they can adjust premiums appropriately. Yeah. It's the unexpected expected costs that, you know, they're the ones that
and that brings up another point. A lot of people think the larger the carrier, the bigger the discounts. No, that's absolutely not true. The larger the carrier, the better they are at predicting those costs because they have a larger pool of people. But what I want everyone to understand, and the example I use is where I live in North Carolina, Lowe's Home Improvement is headquartered in the town, this little town in North Carolina, north of Charlotte. And they are self-funded with Aetna as their PPO network. And the example I use is, let's pretend someone who works at Lowe's goes and has knee surgery at the local hospital, and someone who works for Joe the plumber that has 10 employees with a fully insured Aetna plan goes to the same doctor, same provider for the same procedure coded in the same way. What's the price of those two procedures? Exactly the same. Even though Lowe's has 250,000 employees and Joe the plumber only has 10, that flowed through the same Aetna PPO contract. And so the price of that care was exactly the same. Maybe Lowe's paid a little less because they have less profit on the, on the administration and insurance side, but the price of that claim was exactly the same. So this notion that larger groups of people or larger groups of in the insurance company brings lower costs, that's absolutely not true because the incentives just aren't there for the entities that are controlling it.
Interesting. So then what does good look like for, if I'm thinking about putting together a plan design or a network or, you know, whatever we want to talk about first here, what does an amazing plan include?
Well, first of all, it includes enhancing primary care. And I know that that's been spoken about in the conference. It's something that I speak about quite frequently. As a nation, we spend among the smallest percent of all, at least, industrialized nations on primary care. And the insurance companies helped proliferate that because when you skip over primary care, like if I went to my primary care doctor because my back hurt, he's going to most likely send me to a physical therapist, or he's going to maybe ask me questions. What he's not going to do is drive me to a back surgeon, at least not immediately, because the most likely outcome of going to a back surgeon is, of course, back surgery. And that's one of the interventions that we know has the one of the highest repeat rates. You need another back surgery, another back surgery, another back surgery. So it's not even quality care. So what What good looks like is where we have primary care doctors that are paid properly, that we're incentivized to go to first. They're called primary care for a reason. But even that system was perverted. I don't know if there's any clinicians at the conference, but I want you to understand how the average primary care doctor is paid, especially if they're part of a large health system. They're paid on two metrics. The more patients they see in a day, the more money they make. Of course, the more patients they see in a day, the less time they spend per patient. And a metric that's really, I want this to get more attention publicly, but something called an RVU, which stands for Relative Value Unit. And it's a measurement of how much revenue they're generating in other parts of the healthcare system. So if I'm a primary care doctor paid in that model, as most are, my most profitable path when a patient comes in with back pain is to give them a prescription for an opioid to get them out of my office as quick as possible. And we know opioid addicts largely start with a legitimate prescription taken as prescribed, and send them to my buddy, the back surgeon, because that's where the highest cost intervention is most likely to occur. So I get that patient out of my office as quickly as possible and get them to where the highest cost intervention is going to occur. Now, I really want to say something here. Do I think every broker intentionally puts something in front of a client that's not in their best interest? Do I think every doctor intentionally does care or interventions that are not the most appropriate? No. But there's some bad actors everywhere you go. But at the end of the day, those financial incentives in aggregate are going to win out the day, even if there are some people pushing back against it. And that's why we changed how we get paid in our model when I started over again a few years ago. And we get a flat, transparent fee from all of our clients. And with most of our clients, we have a bonus only from the client. We're prohibited from taking bonuses from anyone else tied to lowering costs. So basically a piece of what we lower the cost by. And that's where we start to align the incentives. Now, we do it at the doctors too. For many of you, I'm sure have heard of something called direct primary care, which is like a monthly membership model for primary care. It's all you can consume for X dollars a month. Those doctors, if they're true, pure DPC, don't have those financial incentives that I mentioned a few minutes ago. And so the good health plan, back to that question a few minutes ago, is where we turn those incentives around to benefit the employer, which is the payer, and the patient, which is the consumer of the care. When you bring those to align them together, that's where amazing things happen.
Yeah, for sure. So just to reiterate what you just said, if we're talking about, when you were talking about the RVUs, the relative value units that a lot of doctors are incented by, I mean, keep in mind, there was just a bunch of research that came out that said the average PCP is worth $500,000 in referrals, up to $1 million. Like there was
not
just
revenue, but referrals.
Right, which basically means that's what the employers are paying for each PCP that's a part of an integrated delivery network actually owned by a hospital. So we're not really talking about every PCP in the country. We're not talking about independent PCPs who are outside of that system and don't get anything, no matter who they refer.
Although they're still largely fee for service. So at the very least, they have that incentive, which still isn't fully aligned, but I agree the RVU is more damaging.
Yeah. And at the same time, you were talking about before that, there's really good people out there. There's any number, every time I talk to a PCP who's stuck, I would say stuck in a fee for service model, these are the people that are getting moral injury because they're forced in order to keep their, in order by the system to, make people come in for a visit who may not need to come in for a visit. And the perverse incentives, they're kind of unwillingly shackled by, let's just say.
That's right. Yep. No, and it really, you can change it everywhere. A question came in on the chat, and the question was, are you paid 100% by your employer clients? Have we eliminated all commissions, overrides, and third-party payments? The answer is yes. It's in our contract with our clients. We get paid by our clients, only paid by our clients, and typically we do a performance bonus tied to lowering costs. So it's a small piece of what we save them, but it's not hard to save a lot of money. So back to the good question. So what's a good health plan look like? Well, we enhance primary care. We want to incentivize people to go to their primary care doctor when that primary care doctor is paid in a proper way. So in some plans, we've created almost like a gated HMO model, but using that direct primary care doctor that's paid properly as the gatekeeper. Not every employer, though, lets us do that. Although I will tell you, when we do, even when the patients at first complain, oh my gosh, I got to switch to a different primary care doctor. I've been going to my doctor for 20 years or whatever. they love direct primary care. And the biggest difference between a regular primary care doctor and a direct primary care doctor is a traditional primary care doctor needs to have 2,000 or 3,000 patients on their panel to feed their daily requirement of, even if they're independent, just to feed the dollars they need to cover their monthly bills and their own payroll. And in a direct primary care model, they don't have that. But not everyone will let us do that. And so we have to change the way care is paid for. The number one way that care is paid for in traditional plans is a discount. Imagine, though, for a minute, if any one of you went into Kohl's and they told you what the discount was, but they didn't tell you the starting price or the ending price. Would you buy anything there? And what if they further told you that you won't know the price until after you buy it, wear it, and take the tags off, and so now you can't return it? Then we'll tell you the starting price, and then you can apply the discount and know the ending price. You know that prices at Kohl's would escalate over time and pretty quickly because they have you. If people were still buying it and we still are buying healthcare, that starting price would keep inflating. And they'll entice you with bigger discounts. But if they raise the discount by 10% and raise the starting price by 40%, you're still paying more money no matter what. So you got to change that model. So the model that we buy into, first of all, there's thousands of providers out there that are just transparent pricing, and not just transparent, but bundled. When you pay for care in a way that says, okay, this is for a knee surgery, and if there's a complication, an infection, a readmission, a redo, that's on the doctor and the facility, not on the employer or the patient. Those things happen less often because right now they're financially incentivized for those types of errors to occur. So that's how we start to change it. And we reward the employee because the outcomes are so much better and the costs are so much lower in that environment that we typically waive the out-of-pockets completely. So the member gets no cost care. HR looks like a hero. The plan is saving a ton of money. The member's getting better care because we're only sending them to providers that are not only transparently priced, but we can validate their quality and their outcomes. And we really create a win-win situation. It's better for the doctor, it's better for the patient, it's better for the employer.
Yeah, I think that's something that many people don't realize, that actually bad surgeons have the opportunity to make more money than good surgeons, because every infection or sponge left in the patient or whatever, then they get paid to take it out.
Yep,
it's
crazy.
I'm laughing. It's really not funny. Well, let me ask you. Let me ask you this. A big fear that a lot of employers have. I mean, let's just get down to brass tacks here. One of the reasons why employers offer health benefits to begin with is to attract and retain talent, right? So if we're tinkering around with the benefits, there's definitely a well-founded fear that we're going to lose employees, at a minimum in the messy middle. So how do you ensure that as you're making these changes and moving to an advanced primary care model, or trying to steer employees to better, effectively facilities, how do you ensure that this is done in such a way that the employees don't feel like they're getting a raw deal?
Well, you're right. There's a lot of fear in that from the employer's perspective. And some employers say, I'm not going to tell my employees where to get care and, where to get medications. And I said, I get that you may not want to do that, but you probably don't want to tell your employees where to sleep at night or what kind of car to drive. But I'd be willing to bet when they're traveling on the company dime, you tell them exactly those things. And they're consuming healthcare on the company dime. And I would argue that you not only have a right, but a responsibility, not just to that particular employee, but to every single other employee on the plan, to ensure that people are consuming high quality care at the lowest price possible. You have a fiduciary responsibility to do that. So that's number one. Number two, there's this weird psychological effect I find. It probably happens in other industries too, but when I ask people, like, objectively, how do you like your health insurance plan? Nobody says, oh my gosh, I love it. It's the best plan ever. It covers everything. It's so affordable, right? So the bar is really low. But when I bring in something that seems different or non-traditional, people psychologically elevate what they have today. And all of a sudden, I'm competing against some artificially inflated ideal. Let's look at what your health insurance is doing. Is there anybody at this conference that at least 8 or 9 out of the last 10 years hasn't seen their costs go up and their benefits go down? And we are eroding away this already really bad thing. And we're worried about losing it. Their marketing machines of the large carriers have instilled so much fear into us over, if I don't have United or Blue Cross, I can't get healthcare. That's not true. Lots of people consume healthcare every single day without those plans. There's lots of ways to pay for healthcare. Your traditional health plan is but one of those many ways. So that's number one. I think number two is talk about statistics. And if you look at especially a lower paid workforce, you're going to find that there are lots of employees that are barely affording their health insurance out of their paycheck and then all their other bills, and they don't have the $6,000 or $12,000 out of pocket that their plan requires them to pay. And so many people either avoid care in these high deductible health plans, split pills, take medicine every other day instead of every day, or go bankrupt. And the number one cause of bankruptcy in the U.S. is medical bills, but nearly 2/3 of those people had health insurance. Now, I don't know about you, but when I took my license for my my insurance many years ago, they taught me that insurance exists for one reason and one reason only: to protect us from catastrophic financial loss. Think about every other type of insurance: life insurance, car insurance, home insurance. All those things are catastrophic events. I need my life rebuilt. They're going to help me do that if that and when that occurs. Health insurance is the only insurance that most people go bankrupt when they actually use it.
Yeah, I mean, as you were just saying, at this juncture, 1 in 6 Americans has unpaid medical debt, right? It's financial toxicity. They've actually correlated to clinical toxicity. So, as an employer also, I think, besides just the benefit aspect of it, it's super important to make sure that healthy, if our employees are healthy, then they come to work. They are productive while they're at work. So,
Yep.
there's a number of different ways that the system fails us. And if patients are so either frightened of the financial toxicity or have cancer and are worried about losing their house, and therefore their outcomes of that healthcare are actually much worse, it's kind of a double-edged sword that's hitting us from both sides.
I can give just probably hundreds and hundreds of examples at this point, but I'd like to give one that I often use relating to my wife, who a few years ago needed a hysterectomy. Now, most women, when they think they might need a hysterectomy or they're told, it's by their OBGYN. And listen, I get it. That's a cherished relationship. I get it. But let's look at some statistics for a minute. There are about 550,000 hysterectomies done in the U.S. each year. There are about 58,000 OBGYNs. Divide the number, you find that each OBGYN does about 8 or 9 hysterectomies a year. Now, I don't know about you, but if I were a major sports player, LeBron James or Tiger Woods, I don't practice 8 or 9 times a year to be one of the top players in my sport. I practice 8 or 9 times a week, maybe more. So the first problem is they're not doing enough to really be practiced and really skilled at it. Second thing is, because they do so few, they tend to rely on the techniques they learned in medical school, which is open surgery. And open surgery comes with higher infection rates. It comes with opioids typically necessary and a much longer recovery time. Even if they wanted to attempt laparoscopic surgery, they have to do dozens of hours of training. They have to spend hundreds of thousands of dollars on additional equipment, all to get a lower reimbursement from traditional insurance plans because they consider that to be less invasive of a surgery. So there's a lower reimbursement rate than an open hysterectomy. Furthermore, the average hysterectomy costs around $38,000 in the U.S. Now, we have a partnership with a team of precision gynecological surgeons around the U.S. They're based in Portland, Oregon, but they have doctors throughout the country. Each one of their precision surgeons does about 300 or 400 hysterectomies a year with a 97% plus laparoscopic rate. And even though the national average is $38,000, we have a prearranged, pre-bundled price of $11,000. So why would an employer not say, look, maybe they don't want to say you have to go there. I get that. And no one has yet said we can tell them they have to go there. But we can say, if you go there, your $5,000 out of pocket is going to be waived. You're going to get better care from a better provider at a better facility, back to work quicker, no opioids. So when my wife did it, she was an hour and 27-minute outpatient procedure. She took ibuprofen. She was back at work 2 days later. And that's the way it should be. And so imagine if you can show an employee, look at how much better this doctor is. And I want you to get better care as your employer, I'm going to waive your $5,000 out of pocket. Or you can go where you wanted to go, and you're going to pay the $5,000 out of pocket. That's how we start to create what we call steerage, although we do change the reimbursement even if they go to their traditional doctor.
Yeah, so part of a good plan is not only having really good advanced primary care, but then also helping when the patient does need a specialist, making sure that they get to a high quality place, which, by the way, is something that traditional carriers have a big issue with because they're so worried about upsetting their existing network. And sometimes they have contractual relationships that forbid
That's right.
steerage. But let me ask you this, David, from a broker standpoint, how's it different for you getting paid by an employer versus a carrier? So if there's, a broker that's listening, who's thinking, maybe I should consider going this route, what should I expect?
Well, I will tell you, the first client that we did this with was a large marine transmission manufacturer and distributor in outside of Madison, Wisconsin. Couple less than 200 employees, 100 something employees. And I remember they were paying me a flat fee, and we agreed in advance to a calculator around savings that then would initiate a check. And every month, the HR director would take a picture of the financials, and she would go, looking good, looking good. And that 12th month, she took the final picture, texted it to me, and said, "You earned your bonus. Where can we send your check?" Like, they were excited to send it to me, and it felt so good because I know that throughout that year, I had a very positive impact on a lot of people. There's something I think a lot of brokers miss, and it's a responsibility that I didn't understand I had until really the last 6 or 7 or 8 years. But I can't think of another professional that a company employs on any level that touches not only the company's finances so deeply, and not only the finances of every employee, but also the clinical of every employee, every spouse of every employee, every child of every employee. I mean, we touch so much of that, and I don't think it's a responsibility that we really take as we should.
So we have about 2 minutes left, but I definitely want to ask you, I mean, this from a broker, advisor, employee EBC, employee benefit consultant perspective, this seems like it's harder. You know what I mean? Like if I'm just a broker, I just look over the gross costs and I don't
Yep.
know. I've never been a broker, so I don't know. It just seems a whole lot easier to throw an employer into a fully insured plan than to do many of the things that you're
It
talking
is.
about. How do I like it? What's my first step here? How do I learn how to do this?
Well, I see someone on the call, I guess one of the attendees, I think he presented too, but David Berg, who's a friend of mine and runs Redirect Health out of Arizona, they have found ways to do this as well as a plan. But I think it's starting with the problem with being paid by the carriers. Again, even if you're a good broker, and I'm going to presume most broker consultants are, the problem with being paid by the carriers is the only box you're going to look in for solutions for your clients are from the box that's going to pay you, right? Because you're not going to work for free and you're used to being paid by someone else. So you're only going to look in this box. But when you get paid by the client, that box disappears. That was the biggest difference. It wasn't that I knew something more. I mean, I had yet to learn a lot of things, but that box disappeared. And all of a sudden, all I cared about was getting the highest quality care at the lowest price for my clients. And I searched ways out to do that, like manufacturer's assistance programs on medications and the bundled pricing and direct contracting and direct primary care, all these things. So there are companies out there like Redirect Health that are already operating in almost like a pre-bundled plan that does a lot of the strategies that I spoke about. So there's a great company to go to say, help me, give me a bundle plan that lets me start to see these things in a way where I don't have to build it. But yes, it is harder, but it's also a lot more rewarding, and not just financially. I mean, a lot of times our bonuses are from one client what it would have been from the entire carrier with the entire block of business. Because if I go in and save a company $2 million, you think they're going to have a problem paying me $200,000? No, they're not. And $2 million is not hard to save, even on a company of just 400 or 500 employees. It's really not hard. So I would start with something like that. And then we also offer a mentorship program where we help people. And my partner, she created a whole course on this. We've also contributed to the Lynchburg University master's level course on healthcare benefit design and financing, put together by Dr. Tom Scott. There's a lot of outlets out there, but what you have to stop doing is stop going to the same well for answers and expecting different results.
That's awesome. So a lot of good nuggets in there. Thank you so much
Thank
for
you.
this conversation, David. I just want to let everybody know that starting soon, at 1 p.m. Mountain Time, that's now, is the tracks. So if anyone wants to hop over into one of those tracks, now would be a good moment to do that. Again, thanks everyone so much.
Thank you.